Chapter 15 discusses disorders of motor function. So we're going to start by talking about just the kind of the general control of the motor system. So the lowest level occurs at the spinal cord. That contains the reflex circuitry needed to coordinate motor units for planned movement. And then above the spinal cord is the brainstem, and then the cerebellum and the basal ganglia. And those structures help to modify the actions of the brainstem systems. And then overseeing the supraspinal structures are the motor sensors in the cerebral cortex. That's the highest level of functioning, which occurs at the level of the frontal cortex. And it's concerned with things like purpose and planning. So you can see that here, right? Here's your spinal cord reflex circuitry that controls our lower motor neurons. Those attach themselves directly to muscle fibers. And then above that brainstem circuitry, you see the cerebellum, thalamus, and basal ganglia. And then the highest level of functioning, the premotor and motor cortex that connects to the upper motor neurons. And so we'll kind of talk about each of those segments individually. So we'll start with the highest level of control, which is the motor cortex. Again, the highest level of motor functioning. And that is the area that initiates and controls our very kind of precise, skillful, and intentional movements. And the thing about the motor cortex to understand is that areas that require the greatest dexterity also have the largest cortical areas devoted to them. So you can see in the brain here the approximate area where the motor cortex is. And then the picture on the right shows the area of the motor cortex that's taken up by different portions of the body. So you can see here, this large portion is just dedicated really to the hands. And then this large portion to the face, because those are really the areas of the body that, again, need the kind of greatest dexterity and control. So they also contain the largest area of the motor cortex. So this is another picture of kind of that motor cortex. So here's the premotor association cortex and then the primary motor cortex. So this is where all of our movement planning occurs. So again, the primary motor cortex right here is responsible for execution of a movement. The premotor cortex is responsible for generating a plan for movement. And then we also have something called the supplemental motor cortex, and it's responsible for performance of complex, skillful movements that involve both sides of the body. So kind of this coordination of bilateral movements happens at the supplemental motor cortex. So a little bit more about the requirements of a motor system. So the picture here shows kind of the motor cortex is kind of here. So upper motor neurons project from that motor cortex to the brainstem or spinal cord. And you can see that here. That is the areas indicated in blue. So you can see those upper motor neurons projecting from the motor cortex down in through the brainstem and into the spinal cord. And those upper motor neurons can either directly or indirectly innervate the lower motor neurons or the contracting muscles that they control. And then a motor unit is a motor neuron and all the muscle fibers that it innervates. So those are usually connected to an upper motor neuron. But we also, remember, need sensory feedback from the involved muscles. So this isn't a one-way street, right? We need information coming back from the muscles as well. And you can see that in red, those sensory units that are projecting themselves from the muscles back up to the brain. So they continuously relay to the cerebellum, basal ganglia, and sensory cortex, the information coming from the muscles. And we also need a functioning neuromuscular junction that provides that link between the nervous system and the activity of muscle contraction. So we need that spot where the neurons connect to the muscles that actually do the work of contraction and movement. We have two major motor pathways within the body that I'll mention here. We have one called the pyramidal pathway, and it travels from the motor cortex and it terminates in the brainstem and in the spinal cord. If people have disorders of the pyramidal tract, which is often the case maybe in conditions like a stroke, they are characterized by things like spasticity of the body and paralysis. There's another pathway called the extrapyramidal pathway, or the EPS. Disorders of the extrapyramidal tracts, things like Parkinson's disease, which we'll talk about in this presentation, result in things that look like involuntary movements or rigidity and immobility without paralysis. So instead of the neuromuscular movement being problems being caused by paralysis, they're immobile because of usually rigidity issues that keep you from being able to move. Okay, so then we'll talk about the lower motor neurons. So lower motor neurons are motor neurons supplying what we call a motor unit. They're located in the ventral horn of the spinal cord, so you can see that kind of right here. Upper motor neurons that project from the brain exert control over the lower motor neurons. So an upper motor neuron stems down from the brain through the spinal cord, and then it synapses with a lower motor neuron that supplies a motor unit. Okay, and that happens down here in the spinal cord. So upper motor neuron traveling through the spinal cord from usually the motor cortex or upper structures down into that ventral horn in the spinal cord. And then we have our lower motor neuron, where we synapse from upper motor neurons, which exert control over the lower motor neurons, into nerve fibers themselves. And here's the motor unit. And the motor unit consists of the motor neuron and the muscle fibers it innervates. And so you can see that here. Here's the neuron, and it comes down and innervates all of these muscle fibers, and where they meet is what we call that neuromuscular junction. So at the neuromuscular junction, this is where we have a synapse between a motor neuron right here and the skeletal muscle right here, okay? And so it consists of the axon terminals of a motor neuron and the specialized region of the muscle membrane called the end plate, kind of right here. And the transmission of impulses is mediated by the release of neurotransmitters, usually acetylcholine, from the axon terminals. So there are these little kind of vesicles full of acetylcholine at the end of the axon terminal. And when a signal travels down through this neuron, it signals the release of that acetylcholine from those vesicles. And then the acetylcholine diffuses out of the axon and travels across that kind of synapse and binds to receptors in that motor end plate on the muscle fiber surface to cause a muscle contraction. And so that's how that like kind of connectivity or communication between the motor neuron and the muscle fibers occurs. So the neurotransmitters of movement, those neurotransmitters being released from the axon terminals, acetylcholine is our major neurotransmitter of movement. It plays a major role in both memory, which we'll talk about in a couple units with things like Alzheimer's disease, but it also is a major player in overall movement. But the other neurotransmitters involved here are dopamine, and dopamine largely plays a regulatory role in movement. And so if we lose the action of dopamine in movement, we get largely just acetylcholine kind of left, and we lose the sort of regulation and the fine control of movement. So what you'll see in conditions where we lose dopamine is that acetylcholine predomination causes a lot of kind of like jerkiness or inability to kind of like exert sort of fine control over movement. And the neurotransmitter GABA also plays a role in movement, and largely also kind of like dopamine, more inhibitory in nature. So it also helps to kind of control muscle movements to make them kind of smoother, again, when acetylcholine dominates, which we'll see in some videos in a bit, you get kind of like sort of herky-jerky, sort of uncontrolled movement. So there are a lot of disorders of the lower motor neurons and the motor neuromuscular junction. So these are disorders largely of those the motor control system that happens from the ventral horn of the spinal cord projecting out into those motor units themselves. So things like muscle atrophy, the disease muscular dystrophy, many of our drug and toxin-induced disorders, myasthenia gravis, different neuropathies, back pain, and herniated disc are all examples of disorders of the lower motor neurons and the neuromuscular junction. I'm not going to talk too much about these. I'm going to focus more on the upper motor neuron disorders and some of the higher function disorders, like things that go wrong with the basal ganglia or cerebellum. But again, these are examples of things that happen in that lower motor neuron area of the neurological system. So we're going to start by talking about the disorders of the cerebellum. So you can see where the cerebellum is located here, kind of just behind the brainstem in the lower region of the brain. And the cerebellum is responsible for the coordination of motor movement. It is vital during rapid muscular activities like running, typing, and talking. The loss of cerebellar function can result in total incoordination of these functions, even though paralysis is not happening. So that's not part of it. It's just a major incoordination issue. All of these individual functions of the cerebellum work to create complete coordination of movement. So there are three kind of major pathways through the cerebellum that coordinate this movement. One is the vestibulocerebellar pathway. It functions in close association with the brainstem vestibular nuclei, and the vestibular nuclei is that coming from the vestibules in the inner ear. And it largely helps us to maintain equilibrium and posture. So maintaining our balance and being able to maintain an upright posture, both while sitting and standing. The spinocerebellar pathway provides the circuitry for coordinating the movements of the distal portions of the limbs, especially the hands and the fingers. And the cerebrocerebellar pathway transmits output information in the upward direction to the brain. So it functions in a feedback manner with the motor and somatosensory systems to coordinate sequential body and limb movement. So it's kind of the relay system between the sensory information coming in and the motor system kind of coming out. And it coordinates a lot of our movements, especially of the body and the limbs. So if there are disorders of the cerebellum, we get these cerebellum-associated movement disorders. Many different things can cause this. Sometimes they're congenital defects, maybe a vascular accident like a CVA or a growing tumor. And there are three different types. So vestibulocerebellar disorders, cerebellar ataxia, and cerebellar tremors. So vestibulocerebellar disorders cause this difficulty or inability to maintain a steady posture of the trunk. We sometimes call that truncal ataxia. So someone with truncal ataxia, either when sitting or standing, cannot maintain that upright posture. So they'll sort of like tip to the side or tip over when sitting or standing, if not like fully supported. And sometimes this is so severe that someone finds it difficult or even impossible to even stand up because, again, they can't maintain that upright posture. Another clinical manifestation we often see in vestibulocerebellar disorders is something called nystagmus, which is the inability to fix the eyes on a target. The word nystagmus here is actually a hyperlink to a video that shows someone with nystagmus so that you can click here and see what that looks like. But it's what we call a constant conjugate readjustment of the position of the eyes. And this makes it difficult for the eyes to focus. These folks often have significant reading difficulties because as they try to focus their eyes on a single thing, they get this kind of back and forth rapid movement of their eyes. In cerebellar ataxia, we get what we call a decomposition of movement. So instead of all of our movements sort of being coordinated and happening together, each component of the movement is now happening completely separately. So movement doesn't look smooth and coordinated. We often get like when we're trying to do rapid alternating movements, they're often really jerky and performed slowly. So, this assessment where we have someone, set the palms of their hands and their legs and then rapidly move them from supinated to pronated position, someone with cerebellar ataxia would not really be able to do that quickly. It would look jerky and slow. Also reaching to a target. So if we ask someone to put their finger to their nose and then their finger to the examiner's finger, that will be very difficult for them. They'll usually miss either their nose or the examiner's finger. They'll overreach or overcorrect. It'll look very uncoordinated. Multiple sclerosis or MS is one of the most common causes of cerebellar ataxia. You can click on the little picture here. This little man is actually a hyperlink to a video of someone with cerebellar ataxia, and you can see kind of some of those assessments that I just mentioned and how those look. And you can also see how their gait changes with cerebellar activity. There's also a link in the notes to a separate video that also shows different neurological tests that are abnormal in cerebellar ataxia. So I encourage you to look at those videos to kind of get a sense of what that would look like in a patient. And finally, we can have something called a cerebellar tremor. Cerebellar tremors are caused by the inability to maintain ongoing fixation of a body part and to make smooth, continuous corrections in the movement trajectory. So usually what we see is a tremor of an arm or a leg, and it's usually detected during the beginning of an intended movement. So we call that an intention tremor. So for instance, if someone starts to try to kind of reach for something, when they're trying to initiate a movement like that, that's when the tremoring really gets kind of worse or is most noticeable. We're going to contrast that to the tremors that we see later in Parkinson's disease, which are usually called kind of a resting tremor, where they're happening when someone's, again, kind of at rest. And so a little different tremoring than what we see with an intention tremor. When someone tries to perform movements or assessments like the heel to shin test or the nose to finger, we can often see that intention tremors start during those movements. Other things to understand that require a lot of cerebellar functioning are things like motor skills of chewing and swallowing. So people with cerebellar dysfunction also exhibit clinical manifestations of dysphagia and what we call dysarthria, which is uncoordinated speech. Then we're going to move on to disorders of the basal ganglia. The basal ganglia are a group of what we call subcortical nuclei. And so here are all your subcortical nuclei here in blue within the brain itself. And they're all kind of interconnected, okay? And the basal ganglia is essential to movement control. So some of those things we talked about back with like things like acetylcholine and basal dopamine and GABA, those kind of control systems are largely functioning through the disorder or through the basal ganglia itself. So that's things like starting, stopping, and monitoring movement. The basal ganglia also regulates the intensity of movement and inhibits any unnecessary ones. So again, things like GABA, dopamine, those neurotransmitters that are involved in kind of the smoothing out of movement to kind of help acetylcholine make things like look smooth and controlled, those neurotransmitters and that control function is largely happening here within the basal ganglia. And so when things go wrong within the basal ganglia, then we get the disorder called Parkinson's disease. And Parkinson's disease is a degenerative disorder of basal ganglia function. And this leads to progressive destruction of the nigrostriatal pathway, leading to reduction in dopamine production. The major type of Parkinson's disease that we usually think about is something called idiopathic Parkinsonism disease. And that's where we just have this primary destruction of basal ganglia function. But you can also see Parkinsonism-like disorders with things like drug side effects, which you'll talk about probably in your pharmacology course. Some people get this in what we call post-encephalitic syndrome, where people have encephalitis or inflammation of the brain. Once that inflammation clears, sometimes people are left with Parkinsonism-like movements. It can happen after a stroke or CVA. It can happen with brain tumors or with repeated head trauma. Muhammad Ali, who was a famous boxer, had Parkinsonism, but it was probably not caused by idiopathic Parkinsonism. It was probably caused by repeated head trauma. So you can see in the picture on the right here, we start with within the substantia nigra of the basal ganglia, we have this destruction of dopaminergic neuronal cells in that area of the basal ganglia. And as those cells are destroyed, we get this overall depletion of dopamine stores from the substantia nigra. And the degeneration of the dopaminergic neostriatal pathway, okay? And that leads to this imbalance of our excitatory, the acetylcholine neurotransmitters, and the inhibitory neurotransmitters, which is dopamine, in the corpus striatum of the basal ganglia. And that impairs the extrapyramidal tracts that control complex body movements. And that leads to the clinical manifestations that we see in Parkinson's disease, like tremors, muscle rigidity, something called bradykinesia, which we'll talk about, and different postural changes. So again, we lose dopamine, acetylcholine predominates, and now we don't have any of that inhibitory effect of dopamine. And so we get a lot of kind of impairment of especially the movements coming from that extrapyramidal tract that controls motor movement. So, etiology and clinical manifestations of Parkinson's disease. So, we're not 100% sure of what causes Parkinson's disease. It's probably a complex combination of environmental and genetic factors. We have found some genes that may be responsible for Parkinson's disease, and we have identified some potential environmental causes. Specifically things like some pesticides and herbicides, especially people who live in rural settings where there's maybe contamination by pesticides and herbicides into things like private wells. One interesting piece about PD is that smoking and coffee actually appear to reduce the risk of PD. I almost never tell you that smoking is helpful, but in this case, it actually kind of reduces the overall impact. But I would still probably suggest not smoking, maybe increase your coffee intake. And I just also want to emphasize that it's not caffeine, it's coffee itself. So it's probably something in the coffee besides caffeine. Okay, and the clinical manifestations really common with Parkinson's disease. So one is tremor, and tremor is usually one of the earliest clinical manifestations that we note with Parkinson's. It may affect mainly the hands and feet, especially to start, but can also affect the head, the neck, the face, the lips, the tongue, or the jaw. It starts as this kind of tremoring that we often call pill rolling. And so you'll start to see it usually unilaterally, usually in the hands, and often the thumb and first and middle finger. And it almost looks like someone is trying to roll a pill between their thumb and first two digits. And it's, again, usually starts unilaterally, so just on one side. And it's usually most often seen at rest. So if someone maybe has their arm supported, like on the armrest of a chair, you'll note this kind of pill rolling tremor in their hand at rest. And then as the disease progresses, the tremoring becomes progressively worse, where it can start to travel to more of a bilateral and then affect kind of more portions of like the limbs, the face, the jaw, and the neck. Another major manifestation is what we call rigidity. And rigidity is most evident during like passive joint movement. And it involves this kind of jerky, ratchet-like movement that requires considerable energy to perform. So any movement of the joints it causes the person to expend a lot more kind of energy for that movement. And just like with tremor, rigidity usually begins unilaterally and then starts to progress bilaterally. Bradykinesia refers to slowness in initiating and performing movements, and often difficulty with sudden or unexpected stopping or voluntary movements. So people with Parkinson's disease, it just takes them a lot longer to kind of like get moving or to stop movement once it starts. So someone with bradykinesia might be sitting there trying to like initiate movement. It just takes them a really long time to do it. And if they're moving along, if you tell them to kind of stop suddenly, it'll be really difficult for them to do that. And it'll be very difficult for them to do it and also maintain like posture. So these are times too where people might be particularly at risk of falling. People with Parkinson's disease also have this really distinctive gait, and we call it a shuffling gait. So when people with Parkinson's disease walk, their arms are kind of like rigid at their sides. They don't really swing their arms with movement, and they also don't really kind of pick their feet up with movement. They also have this sort of distinctive stooped posture. So picture someone kind of slightly stooped over, sort of looking sort of toward the ground with their arms like hanging sort of rigidly at their side and their feet just kind of like sliding along the ground in sort of slow, uncoordinated movements. That's what the gait of someone with Parkinson's sort of looks like. This kind of slow, shuffling gait. As I mentioned earlier, the people with Parkinson's are at high risk of fall. They have a hard time sort of maintaining that upright posture. And when they do fall, they often fall backwards, which is an unusual way to fall. Most people typically kind of fall forward or to the side. These folks fall backwards. Over time, they also lose the coordination of movement in their face. So they get that same tremoring and rigidity of their face. And so this causes them to lose the ability to make different facial expressions of emotion. So a common clinical manifestation you see with Parkinson's patients is this sort of mask-like facial expression. So they're unable to like express any emotions really at all with their face because of loss of movement of those that muscle control. They also develop problems with the muscles in kind of their mouth that allow us to speak and to swallow and chew. And so they often drool and their speech becomes kind of slow and uncoordinated. They also lose control of the autonomic nervous system functions. So they might sweat profusely. They get dysphagia or swallowing difficulties. A very common clinical manifestation we see in PD is orthostatic hypotension, again, because of the loss of that autonomic control. And so it also adds to that significantly increased risk of falling in these patients. And PD patients can also lose things like thermal regulation, so inability to control their body temperature. Dementia also occurs in about 20% of people with Parkinson's disease, so is also a significant clinical manifestation. So Parkinson's diagnosis and treatment, we really don't have like one definitive test diagnostically for PD. So we usually do it based on things like medical history, symptoms at time of presentation, and a complete neurological and physical exam. Treatment for PD is really symptom management only. We do not have a cure for Parkinson's disease. We just manage the symptoms. So we have some non-pharmacological treatments, so things like education, support groups, daily exercise regimens, and good nutrition can help to slow the progression of Parkinson's disease. And we also have a lot of pharmacological measures. One thing to note here, though, is as I mentioned, we have idiopathic Parkinson's disease, and then we have secondary causes. Pharmacological treatments usually only work with idiopathic Parkinson's disease. They're really the only thing that responds to this. So we have drugs that will increase the overall levels of dopamine in the body. We also have drugs that will stimulate dopamine receptors directly. And we have drugs that stop the breakdown of dopamine at that neuromuscular junction or synapse. And so that dopamine can kind of hang around there at the synapse longer and exert its effect. We can also use anticholinergic drugs that can blunt the cholinergic overactivity that we often see in Parkinson's disease. So again, kind of two targets of pharmacological treatment. We can either try to increase the overall activity of dopamine through those three separate mechanisms, or we can try to blunt or reduce the activity of acetylcholine to try to smooth out or reduce the symptoms of Parkinson's disease. There are also some surgical treatments that we may be able to use, especially in advanced Parkinson's disease. One thing that we sometimes use are deep brain stimulators, usually for people who maybe responded to Parkinson's medications like levodopa, but they had way too many side effects to be able to tolerate it. And so then we can maybe try deep brain stimulation in those patients instead. Now we're going to move on to some other upper motor neuron disorders. And so these are disorders involving neurons that are fully contained within the central nervous system. So they include the motor neurons that start in the motor areas of the cortex and their fibers as they project to the spinal cord. So you can kind of see that here. Here are our upper motor neurons projecting from the motor cortex, traveling down through the brainstem and into the spinal cord, where they'll eventually synapse with those lower motor neurons in the ventral horn. Okay. Some common diseases here are things like amyotrophic lateral sclerosis, or ALS. That's actually a mixed upper motor and lower motor neuron disorder. And other disorders here that affect only the upper motor neurons are things like multiple sclerosis and spinal cord injury. So we're going to start with amyotrophic lateral sclerosis, or ALS. So ALS is a devastating neurological disorder that selectively affects motor function. The other common title for this is Lou Gehrig's disease. This disease typically follows a progressive course. Most people who are diagnosed with ALS survive anywhere from 2 to 5 years from the onset of initial symptoms. And ALS is far more common in men than in women. So twice as many men are affected by ALS than women. So the location of the motor neurons affected by ALS. So it can affect the lower motor neurons of the spinal cord. It can affect the motor nuclei of the brain stem, particularly something called the hypoglossal nuclei. And the hypoglossal nuclei is a cranial nerve nucleus, and it's found within the medulla of the brainstem. And it's the motor nucleus responsible for tongue movements that allow both speech and swallowing. So that motor nuclei directly from the of a cranial nerve is what allows us to speak and to swallow, and that is affected by ALS. ALS also affects the upper motor neurons of the cerebral cortex. The death of the lower motor neurons that are affected by ALS leads to denervation, and then we get shrinkage of musculature and muscle fiber atrophy. So one of the common clinical manifestations you see with patients with ALS is this overall muscle atrophy kind of throughout the body as they lose that lower motor neuron innervation, and the muscles aren't activated and they just start to kind of shrink and atrophy. So the clinical manifestations of ALS. So we have manifestations that occur because of the destruction of our upper motor neurons. and that is things like weakness, spasticity and stiffness, and impaired fine motor control. We also get dysphagia, so inability to swallow. They get recurrent aspiration. We also see weakness of the respiratory muscles. Um, we also see things like dysarthria or problems with speech. And we also get dysphonia, and this may result from brainstem motor neurons. So this is the inability to produce speech. The manifestations of lower motor neurons include things like fasciculations. This is abnormal motor movement. They get weakness, muscle atrophy, and hyporeflexia. So in more advanced stages, the muscles of the palate, so inside the mouth, the pharynx, the tongue, the neck, and the shoulders start to become involved. And so people are unable to chew, swallow, or produce any speech. And again, as I mentioned, we also get weakness of the respiratory muscles of the trunk. And that really produces the most significant acute complication of the disease. So death from ALS usually results from involvement of cranial nerves and the respiratory musculature. So these folks are no longer able to speak, swallow, or breathe. There is no cure for ALS, so management is really challenging and requires multidisciplinary teams to manage the symptoms. So major symptoms are things like maintaining nutritional status when someone loses the ability to swallow, maintaining the ability to breathe when people have respiratory muscles that become compromised and weak. So often patients will have things like tube feeding. They may be on mechanical ventilation, and this really allows them to kind of live longer with ALS on kind of all of those advanced life support sort of mechanisms. We'll talk about multiple sclerosis. So MS is a upper motor neuron disorder where we see this overall demyelinating of the upper motor neurons within the CNS, but the motor neurons within the peripheral nervous system are usually spared. MS is the most common non-traumatic cause of neurological disability among young and middle-aged adults. It's characterized by exacerbations and remissions over many years in different sites in the central nervous system. So exacerbations and remissions means sometimes the disease gets worse, and then it goes into remission periods where people have relatively low levels of symptoms. Initially, there's usually normal or near normal neurological function between exacerbations. But then as the disease progresses, there is less improvement between exacerbations and increasing overall neurological dysfunction. So MS is characterized by the inflammation and destruction of mostly myelin within the central nervous system. MS is probably an immune-mediated disorder that occurs in genetically susceptible people. So the pathogenesis of MS. So lesions form within the CNS consisting of hard, sharp-edged, demyelinated patches throughout the white matter and occasionally in the gray matter of the CNS. These lesions, which represent the result of acute myelin breakdown, are called plaques. Plaques initially usually form in the optic nerves, the periventricular white matter, the brainstem, the cerebellum, and the spinal cord white matter. So the pathophysiology of MS involves the demyelination of nerve fibers, again, in the white matter of the brain, spinal cord, and optic nerve. So the purpose of the myelin sheath is to act as an electrical insulator, and it reduces electrical resistance in the nerve fibers. And this makes electrical signals within those nerve fibers move more easily. So in MS, as the myelin breaks down, without myelin, that electrical movement is slower, and as myelin breakdown progresses, sometimes may become blocked in those nerve fibers. So you can kind of see that in the picture. You see that the axon membrane itself is wrapped up in all of this myelin sheath. And again, that acts as sort of an electrical insulator, right? So if you think about maybe how an electrical cord that you use in your house is made up, you have the cord itself that's wrapped around with all this kind of like plastic material to sort of insulate it, and your nerve fibers work the same way. And if you get just unmyelinated nerve fibers, that electrical activity does not move as readily down the nerves themselves, and if that myelin sheath breaks down enough, it can stop moving at all and just kind of become blocked at that point where we see that myelin breakdown or plaquing. So the course and clinical manifestations of MS, demyelination clinical manifestations really depend on the severity as well as the location of plaques. So the clinical manifestations you see are going to largely be determined by where the plaquing is occurring and how much of it has happened. Okay. I mentioned that one of the major places and one of the early places that we see demyelination is within the optic nerve. So some of the early signs of MS are often changes to someone's visual field. And these can be sort of minor and something that maybe someone notices, but sort of discounts, right? They may go to an eye doctor, they may have different eye tests, but that early clinical manifestation is often sort of, unnoticed. We also see changes to the cortical bulbar tracts that are involved in things like speech and swallowing, to the corticospinal tracts, and so changes to muscle strength and tone might occur. We can see demyelination in the cerebellar tracts, and so we see changes to things like people's gait and coordination, so things like the ataxia that we talked about earlier. We see demyelination in the spinocerebellar tracts, so changes to things like balance. We also see paresthesias, so things like numbness and tingling. And we can see loss of bowel and bladder function as well, and also loss of sexual function. So we have kind of four general courses of MS that we can see in people. One is called relapsing and remitting. And the relapsing and remitting form of MS is characterized by episodes of acute worsening of the disease with recovery and really stable or mostly asymptomatic courses between relapses. In secondary progressive disease, this involves gradual neurological deterioration with or without superimposed acute relapses. We often see this in a person who previously had maybe relapsing and remitting disease. And so this is when, there's no longer, again, kind of those symptom-free relapses. Now instead we see just really sort of gradual deterioration with no periods of symptom-free time. And superimposed on that gradual deterioration, they may still have like acute episodes where symptoms get worse, and then they never really return to a symptom-free state. So that's secondary progressive disease. In primary progressive disease, this is characterized by nearly continuous neurological deterioration from the onset of symptoms. So unlike relapsing and remitting forms, once someone with primary progressive disease is diagnosed with MS, they just have continuous deterioration with no remissions. So there's no periods where they have symptom-free times. They just gradually deteriorate. Progressive relapsing category of disease involves gradual neurological deterioration from the onset of symptoms with subsequent superimposed relapses. So these folks not only have just progressive decline, but they'll have acute episodes where they have superimposed relapses. So kind of four different ways that MS can appear in a person. There is no definitive diagnostic test for MS. We usually diagnose this based on symptom severity and duration. We can detect MS lesions on MRI, usually when they're a little bit more formed or severe. MS can be very difficult to diagnose. It can take years for someone with symptoms of MS to really get a definitive diagnosis because it can show up in so many different ways. It can show up with many different types of symptoms. Many times, again, the symptoms are really kind of vague. And there's so many different courses of the disease that sometimes people have, maybe some very vague symptoms, and then they go into a remission period where they don't have any at all for extended periods of time. So it can, again, be really difficult to diagnose this disease and can take a considerable amount of time to be able to do so. There is really no definitive treatment or cure for MS. It's really mostly just supportive. Sometimes we use things like muscle relaxants, those kind of things to control symptoms. So then we'll move on to spinal cord injury, or SCI. And this is damage to the neural elements within the spinal cord themselves. Causes are things like motor vehicle crashes, falls, violence, sporting activities, usually some sort of traumatic event that directly damages the spinal cord itself. Most spinal cord injuries involve damage to the vertebral column and/or the supporting ligaments, as well as the spinal cord itself. And when we have spinal cord damage, it usually involves both sensory and motor function because both of those functions travel through the spinal cord. So different types of injuries that can damage the vertebral column. It can be fractures, dislocations, or subluxations. So different things like force through the spinal cord causing fracture. It can be twisting forces, but yeah, again, mostly traumatic forces. So dislocations or subluxation injuries displace the vertebral bodies with one kind of overriding another, and that causes misalignment of the vertebral column. Damage to the ligaments or bony vertebrae may make the spine unstable. And in an unstable spine, unguarded movement of the spinal column can kind of impinge on the spinal cord or spinal canal, causing compression or overstretching of the neural tissue. And all of these things can lead to damage of the spinal cord itself. We have two major classifications or types of spinal cord injury. One is complete, where there is complete destruction of neural tissue and upper motor neuron or lower motor neuron paralysis, as well as complete loss of sensory function. But you can also have incomplete SCI, where you have some residual motor or sensory function below the level of the injury. Incomplete injuries can be organized into certain patterns or syndromes of SCI. So things that are affected by SCI, one is our spinal reflexes. So this is loss of control of lower motor neurons by the upper motor neurons. And this can result in things like hypertonia and spasticity of skeletal muscles below the level of injury due to reflex control. So if you damage the spinal cord itself, you're really damaging those upper motor neurons that pass through the spinal cord in that case. And so remember that upper motor neurons exert control over the lower motor neurons. And the lower motor neurons really are responsible for a lot of the reflex activity we see between the spinal cord and the muscles themselves. And so if the upper motor neurons are damaged, we don't have that control of the lower motor neurons anymore. There's complete loss of that upper motor neuron activity. And so now all we have left is the lower motor neuron that travels from the spinal cord itself to the muscle. And so that thing is not controlled anymore by the upper motor neuron. And so all it can do is kind of send out this sort of spastic, sort of like uncontrolled signal to the muscles. And so they become hypertonic or sort of like constantly contracting, or they're spasming. And that's what we often see when we have lower motor neurons that are still intact without upper motor neuron control, spasticity and hypertonicity. Okay. We can also get ventilation and communication defects with spinal cord injury. And this really varies based on the location of the lesion in the spinal cord. If we have lesions that are in C1 to C3, so cervical spine between cervical areas 1 and 3, this is such a high level of injury that people with this type of injury may require total ventilatory support to maintain breathing. And they also may lose their ability to communicate, again, because of that high level of injury. Everything below that level of injury will be affected. Damage below the level of C5 usually causes problems with things like deep breathing and coughing because of damage to the muscles in the trunk. The autonomic nervous system is also affected in the case of spinal cord injury. So if there's a spinal cord injury, all autonomic nerve function below the injury site will be stopped. So you can see in the picture here, we have a spinal cord and the area of injury is kind of right here. So any autonomic activity happening below that area of injury, so any information coming back in and going back out of the spinal cord will be uncontrolled. So autonomic reflexes that are uncontrolled, what we get are autonomic reflexes uncontrolled below the level of the injury, but controlled above the level of injury. And this can cause things like uninhibited, like vasovagal responses that can cause marked bradycardia in our patients. And it can also cause a condition called autonomic dysreflexia. And this represents an acute episode of exaggerated sympathetic reflex responses, usually in people with injuries at T6 and above. And this is where the CNS control of spinal reflexes is lost. And it's characterized by things like mild to severe hypertension, skin pallor, and something called the piloreceptor response. And this is when kind of like the hairs on your arms and extremities sort of stand up. Autonomic dysreflexia is a clinical emergency. It can cause things like convulsions, loss of consciousness, and death if it is not corrected. So we'll talk a little bit more about kind of how that happens. And so again, you can see in this picture, this is the level of injury right here. And so when something happens below that level of injury, that would trigger the autonomic nervous system. So in this case, it is a visceral response, like an over-distended bladder. And so that sends a signal back into the spinal cord, but now we don't have autonomic response that is controlled below that level. So uncontrolled activation caused by this bladder overfilling causes really local sympathetic reflexes to happen below the level of injury. So we get things like piloreceptor or goosebump kind of stuff below the level of injury. And that uncontrolled activation also causes vasoconstriction below the level of the injury. So we'll see things like pale, cool, and mottled skin, again, below the level of that injury in the spinal cord. But that vasoconstriction, which is, again, uncontrolled, causes this acute rise in blood pressure. And that activates the baroreceptors. And when those baroreceptors are activated by a rise in blood pressure, they signal this response to slow the heart rate by the vagal nerve. And they also signal vasodilation. But because we have this spinal cord injury, that vasodilation only occurs above the level of injury. It only occurs where we have autonomic nervous system control. So nothing below the level, so that will remain pale, cool, piloerect, all of those things. But in the upper part of the body, we see things like flush skin. These patients can get headaches because of all this vasodilation. But we still have this vasoconstriction below with an acute rise in blood pressure. So we have high blood pressure, low heart rate. And again, this is a medical emergency, okay? So how do we correct this? Well, we correct it by taking away whatever signal caused this to start in the first place. So we have to correct the initiating stimulus. So in this case, like in the picture, we would need to empty this person's bladder um, to reduce that autonomic sensory stimulation. Okay. So while we're working to correct this cause, we need to be closely monitoring this patient's blood pressure. We should put this person in an upright position. Any binders or supports should be removed that would be inhibiting like venous return. We don't want any venous pooling of blood. We want to make sure we can fully support venous return, that kind of thing to help with vagal response. These folks are also really prone to things like postural hypotension. So when sitting up, they may be really dizzy. Again, that's really the description of autonomic dysreflexia, which is something that can often occur because of autonomic dysregulation in these patients. Patients with spinal cord injury also experience things like temperature dysregulation. Spinal cord injury can disrupt the communication between the thermoregulatory centers in the brain and the sympathetic effector response below the level of injury. They also often develop things like edema, and they're at high risk of deep vein thrombosis in SCI because of immobility. They also, because of loss of ANS control, have decreased vasomotor tone below the level of the injury, and that causes hypercoagulability and stasis of blood flow. So monitoring these folks for DVT is important. And they also get significant loss of sensory motor function. Skin breakdown is one of the most preventable, but is also a very common complication of SCI. People with SCI lack the sensory input to know to move, so they don't have that signal, that pressure signal that would tell them to shift position. And they also often don't have the motor function to be able to do it. So they are at very high risk of skin integrity impairments, and they need to be monitored for that. They need pressure relieving devices, both in their chairs and in their beds. And they need very frequent skin assessments. One of the things that often leads to mortality in SCI patients is major decubiti ulcers that can become infected, leading to death. They also have reduced pain reception, which causes increased risk of skin breakdown. Other things, they may lose things like bowel and bladder function, and they often experience sexual dysfunction in SCI.